Say a big thank you to Siri and all the folks at the CFRI for inviting me to be part of this meeting. It's been a long time since I've been here in person, and it just always overwhelms me what a great conference this is and how amazingly interactive it is, which I love. So feel free to ask questions, and if we run out of time, I'm happy to talk to anybody on the side. These are my disclosures. I am going to largely, despite my interest in hormones and menopause and many topics, I just wanted to keep this relatively refined and focus it on reproductive health. So I'm mostly going to be focusing on that aspect in my talk, both for males and females. So just to give you a little bit of background, I think we heard so nicely from Amit already that the landscape in CF is really changing. These are a couple of graphics from the CF Foundation's registry data, where if you look on the top here, this green color represents the population of children within CF, and the blue color represents the population of adults over time, going back from the mid-1990s to really about 2023. And it used to be, back in the beginning, you can see that over 60% of the population was children. Now you look over on the right side, and about 60% of the population is adults. And with that, I think we heard so beautifully from Amit that really a lot of the questions have changed. And my interest in this really has been sparked from people with CF asking me questions in clinic that I really felt like I wanted to answer, we needed to answer. And I definitely can't say that we have all those answers yet, but we're getting closer, which is so important. This bottom graphic, I think, is also really important. In addition to people with CF getting older, I think we heard just a minute ago that you don't just want to get older, you want to get older well and enjoy life. That you can see here on the bottom that this is another graphic from the CF Foundation Patient Registry, that amongst those 18 and older, nearly half of those now are married or living with a partner. And I'm not saying that that equates to a better life, but I think it's a sign that people are living ways that they thought they wouldn't necessarily be able to live many years ago. And this too has lent itself to questions about pregnancy, parenthood, all sorts of other questions related to reproductive health. So this is also, I think, a really clear graphic of the reality of what we're living with in the world of CF, which I think is to be celebrated, and that is the baby boom that's occurred in CF. You can see that this is really the number of pregnancies that have occurred in females with CF ages 14 to 45 over time. And it used to be very steadily that in the early 2000s, 2010s, that we would see anywhere from 200 to 300 females with CF experience a pregnancy per year. Those numbers, after the introduction of ETI or Trikafta, exploded, where it really nearly doubled, and this has been consistent ever since. And this is not just a phenomenon in the United States, we're seeing this around the world, which is very exciting. It does lend itself to asking, why may that be the case? And we don't exactly know yet, but there's some hint that modulators such as ETI impact fertility. And how and why would this be? You look over here in this slide, and this is a depiction of the female reproductive system, where you look at the uterus in the middle, where there is expression of CFTR. The fallopian tubes and the ovaries also have expression of CFTR, but very importantly, the cervix, which has a lot of epithelial cells. Epithelial cells are those same cells you hear about in the lungs or the airways that are full of CFTR. They have the highest expression of CFTR in the reproductive tract. And that really, if you think about it, what that was doing when CFTR doesn't work is just like in the lungs, when secretions are viscous and dehydrated if CFTR is not working, the same thing was happening in the cervix, causing this thick, sticky mucus that you can see over here on the top. And then the other things that we don't think about but are also occurring is CFTR also regulates the acid-base balance in all organs in our body. And in the reproductive tract, by not having CFTR work appropriately, this decreases the pH or makes it a more acidic environment. And actually what that means is in reality, the uterus is a fairly basic organ and it needs that basic environment, because when a sperm gets into the uterus, it goes through a lot of processing, and part of that processing requires that high bicarbonate environment. So that it was yet another reason why we thought fertility might be challenging in CF. Now, for decades, females with CF have been able to have babies, but in certain cases it was more difficult. And we're just finding now that there are many reports of it becoming easier and easier. And we think that the thinning of the cervical mucus And this increasing of the pH that was previously low may be a few of these reasons. We can't say for sure, but there are certainly slowly developing data to suggest that this may be the case. And this is really a case report that actually came out of my center that really highlights this very nicely. And this was a woman we followed who was 31 years old. She was in relatively good health with a lung function in the 80s, BMI 22, sweat test that was fairly low at 63. But she had been struggling to get pregnant actually for years. And she'd been to fertility doctors, et cetera, and actually had an evaluation where she had what's called a hysteroscopy. And in this hysteroscopy, if you can see, they take a camera into the cervix and in the uterus, and they saw these really thick, viscous strands of mucus in her uterus, and really felt like this was why she was unable to conceive, that it just wasn't an environment conducive to having a child. And, she was actually in the process of thinking about trying to go through reproductive technology to have children, when lo and behold, she actually became eligible for ivacaftor or Kalydeco. We started her on Kalydeco, and she described what she termed a vaginal purge. I think many of you have heard of the respiratory purge people experience with starting modulators where they cough up a ton of sputum. She really described the discharge of a huge amount of vaginal mucus. And she was smart enough to say, could this have changed my ability to have children? She went back to her fertility doctor. They did another one of these hysteroscopies, looked in her uterus, and you can see that those vaginal mucus strands in there had completely cleared. And lo and behold, I'm happy to report she was able to naturally have a baby. And that baby, I think, is now maybe 3 years old. He's beautiful, healthy child, and she couldn't be more happy. So, it's stories like this that has really challenged me to try to learn more and help have a few more answers to questions people with CF have about their reproductive health. With this story, it also challenged me to think about, am I counseling enough? And whoops, what happens when I'm not? And we also experienced after the release, particularly of Trikafta, and I'm sure many of you have had friends that this has occurred with, or at your own centers, for those of you who care for people with CF, that we also saw a number of unplanned pregnancies. Now, this is common outside of the CF population, but in general, I tend to view the people I care for with CF as asking a lot of questions, being really thoughtful, planning a lot of aspects in their life. And I had not really come across this. But after the release of Trikafta, we really saw a number of unplanned pregnancies, because for people like the woman you just heard, many of them thought they could never have children, and then suddenly they were. And that's okay. Most of these stories turned out wonderfully, so it's good. But some of us wanted to take a look at, should we be worried about this? Should we be counseling? What's the impact of a planned versus an unplanned pregnancy? So this is a study that many of us got together and did by collecting the data from our centers. And this was over 11 centers in the United States, including in Boston, Alabama, California, et cetera, all sorts of places. Looked at the data, and fortunately, knowing our patients very well, we knew who had planned versus unplanned pregnancies, took a look at what these outcomes, at least when it came to lung function over on the left and pulmonary exacerbations over on the right, just to compare pre and post pregnancy, what did we see in terms of the trajectory of lung function and the impact on pulmonary exacerbations. And you can see over on the left-hand side, there was a slight decline in both, but actually no difference in that decline between someone who planned or didn't plan their pregnancy. But when you look over on the right, you can see that in the unplanned group, which is in gray, relative to the planned group in black, that there was an increase in pulmonary exacerbations. Now, again, every individual is different, so this is just pooling the data together, but it at least gave me the remembrance to think about, okay, this can have an impact on somebody's life, it can have an impact on their child, et cetera. So we've got to do a better job counseling. And by counseling, I mean talking about contraceptive options. I know many of us, like myself, might be pulmonologists or gastroenterologists or endocrinologists in clinic, but it's still our obligation when it impacts any aspect of their health to at least try to do a good job about touching on this issue, because it is connected with their CF. As I mentioned, many of them don't know that they are fertile now if they weren't before, et cetera. And or haven't even had their fertility tested in some way. But this is the contraception options are no different for somebody with CF as somebody without CF, but there may be some unique things to think about. I do want to point out with what we do know about contraceptive information, at least with females in the United States, the most common option still being used is oral hormone contraceptive therapy, but many choose more effective devices like IUDs, et cetera. And there's intricacies to all of these. And I just want to point out a few to think about. Particularly, you may want to talk to your own care team about, is this something I should do, my child should do, et cetera. But a few things people tend to worry about. One is the potential effect that hormone contraceptive, particularly estrogens, may have on blood clots. The risk overall is low, but if you're someone who's, for example, has had a number of blood clots with PICC lines or with Mediports, et cetera, then you really want to have a big discussion with your OB-GYN or your CF provider on whether or not that may be the right option for you or whether you want to choose a non-hormonal based option. The other things people worry about is if I'm on a lot of antibiotics, is that going to render my hormone contraceptive ineffective? It's relatively uncommon, but it can occur. And I know at our center, we tend to tell people that when they're on an antibiotic, please use a second form of barrier protection, et cetera, just in case. So, you don't have that impact where your hormone contraceptive is not working. Other aspects are people worry about a potential increase for osteopenia or osteoporosis, which is accelerated bone loss. This is particularly the case in progesterone-only based therapies. But again, that's not common. It's a long-term effect. It is one of those things that your OB-GYN, your endocrinologist helping you with your bone disease, your CF provider might be able to talk to you about, where, for example, people who used to use Depo-Provera, which is more of a progesterone-based long-term contraceptive, they do have limitations on don't use it over this many years because it has this potential. So there's some ways to combat that. And I think finally, a question that comes up a lot is, now that I'm on a CFTR modulator, should I be on a contraceptive? What's the interaction? Is this going to be a problem? And I do want to be, very clear to say that from what we know about ivacaftor or Kalydeco, Tazyva or Symdeko, and ETI, which is Trikafta, and now Vanzacaftor, which is the triple combination called Aleptrek, none of those are expected to impact hormone contraceptive therapy. There's not a known interaction, so they're safe to use together. It won't render either one ineffective, but there is a possibility of that with Lumacaftor, Ivacaftor, which is Orkambi. I think there are less and less people on Orkambi right now, but that really caused a lot of people to have misconceptions of all the modulators having that, which it's not the case. So, I do encourage you, your family, et cetera, talk to your provider if this is something you've been concerned about, because there may be many different potential options for you that can allow you to plan family building, et cetera, if that's something in your future that you're interested in. So I think the next big question I tend to get about reproductive health, particularly from the females I take care of with CF, is what is the impact of becoming pregnant on my health? And I think along with that, what's the impact that my future child might have by me having CF? And I'm really happy to report there had been little by little, we're getting newer and newer data, but over a long period of time now and looking at large data sets, this one coming from the CF Foundation Patient Registry that actually came out of Dr. Paul Mohabir here at Stanford just recently, looking at data on any females with CF who'd experienced a pregnancy versus those who had not in the registry. They very nicely, as has been reported in the past, found there is no survival difference if you've experienced a pregnancy or not. So that's one of the greatest things to know, that you can feel comfortable thinking that you can have a child and this isn't going to impact your long-term health. Then what do we know about short-term health? There's a lot more variability there when it comes to the studies, that it's not nearly as clean as the survival studies. This is one study that came out of Israel, but actually included a number of countries, including the United States, again, looking at a retrospective, meaning looking backwards at data on what the impact of pregnancy is more short-term in females with CF. And they divided this up to try to handle some of the individuality we talk about, where they were looking at people who had a little bit more moderate to severe health illness, which they defined as an FEV1 of less than 60%, those who had pancreatic insufficiency, those that were colonized with Pseudomonas, et cetera. And the big take home I'll tell you that they found is they found that in those that did have somewhat lower lung function, that there was a little bit of an association with the baby being born premature, which has already been known to actually be a bit of a risk factor in females with CF. They also found that in those who had pancreatic insufficiency and Pseudomonas, both of those, that there may be a more rapid decline in lung function during pregnancy, but that it stabilized later. And in those that had pancreatic insufficiency, there was a little bit of an increase for the baby being born small for gestational age, which has also been described in CF before. Now, importantly, this data, if you look at when they collected it, was in 1986 to 2018. So really did not touch on the modulator era at all. So keep that in mind, because I don't know that we have, this type of detailed information in the newer era of CF care. So just be cautious if you're ever thinking about yourself or counseling people you care for, that there's a lot of nuances in these types of studies to think about. So looking a little bit, this was actually again that 11 group of centers I told you where we got together and looked at planned and unplanned pregnancies. We also wanted to take a look at some of the shorter term outcomes on health in females with CF in this modulator era, at least touching on the modulator era. And what we did is look at lung function prior to pregnancy and post-pregnancy, and exacerbations prior to pregnancy and post-pregnancy, breaking the population up into those who had been on a modulator while pregnant and those who had not been on a modulator while pregnant. And importantly, of those on modulators, the majority of them were on what we would term highly effective modulators, which is Trikafta, none were on Elyftrek at this time, but Trikafta and Kalydeco. And so you look at this, and actually it used to be, if in the dotted line, those are people not on modulators, that they did have a slight but a notable decline in their lung function after pregnancy that actually was not present in those on modulators. You look at the exacerbations, and there was just, there was really no difference in exacerbations on those not on modulators, but you look those on, and there was actually an improvement on those in modulators. Now, part of that improvement, meaning less exacerbations, may have been the timing of this too, that this was when modulators were relatively new, so they were probably experiencing a decline partly for that. So the take home would really be that some of the concerns we might have had about lung function or exacerbations, et cetera, are looking better in early data, at least for females who are on modulators during their pregnancy, which is really exciting to hear. Now, this was a smallish study with about 300 or so pregnancies, but we're currently actually taking a bigger, deeper dive into this using CF Foundation registry data. And this is just really looking at what this graphic is on the left this is lung function over time in any females with CF in the registry who'd experienced a pregnancy in that dark solid line, and those who had not experienced a pregnancy in the dotted line. And this is not yet published, but we're going to be presenting this data at the North American Conference this fall, where you can see that trajectory over time is fortunately fairly identical. Now, the pregnant group actually starts out with a little bit of a higher lung function, which we have seen in many studies before. And that's likely to be explained by the fact that in general, I think people who plan their pregnancy, experience a pregnancy, tend to be on the healthier side or go into it wanting to be on the healthier side. But you can see over time, that ends up with no change in their trajectory. And if you're wondering what that blip is that caused that big change, that was basically because modulators hit, and that's what we're seeing in general in the registry with their trajectory of lung function over time. We also took a look at pulmonary exacerbations in these two groups, and fortunately found that when you look at whether there's any difference pre or post pregnancy, there was nearly none, what we would call a rate ratio of 1.03, which means a 3% difference, which is not at all a difference. So really good news again, that really would suggest that now not only from a survival standpoint, but looking at lung function, looking at exacerbations, that we're seeing females that experience a pregnancy do as well as females who don't experience a pregnancy, which is terrific. So that then lends itself to the second piece of the question that I hear all the time, and that is, what about the impact on my child? What can I expect? Should I be worried? Now, I would say we have much less data in this area. And so I say everything I say just expressing what we know, but there is a lot more to learn because much of this data also is retrospective and fraught with data collection issues where often we're missing this type of data in the literature. But this is one of the nicer studies that I wanted to point out that really came from the UK and data that they collected looking at, are there associations between maternal health and infant outcomes? I think that's something I often hear from the women I take care of where they say, am I healthy enough to have a child? We definitely don't know that answer or those numbers of what to tell them on should your lung function be this, should your body mass index be this, et cetera. But this at least gives us a glean where what they did is in a small number of people, about 70 pregnancies, again, in data that was from 2015 to 2017, so before modulators, they really took a look at the correlation between lung function that's on this x-axis or the horizontal axis to the weeks of pregnancy, meaning essentially the gestational age of or how many weeks at birth those babies were, and the birth weight of those babies. And I mentioned earlier, there's already some data to suggest that babies born to mothers with CF are born a little bit early and a little lower in terms of birth weight. But you can really see that this does give us at least a trend. It's not a clear, clean, but a trend that the better a mom's lung function is, that the longer or more full term their pregnancy might be, and the more normalized the weight of that baby might be. Again, a little bit older literature, and you can see it's not that this is some one-to-one relationship, but it gives us a sense of, encouraging our patients, try to stay. I mean, they're already trying to stay as healthy as they can, but the healthier you go into it, chances are the easier that pregnancy will be, and hopefully the healthier that baby will be when born as well. So other things we know, this actually is just a couple of relatively older but large database evaluations of pregnancy in CF. And I'll just summarize it by saying they did large looks at electronic medical records, taking all people who have had pregnancies, pulling out those who had CF to look at what infant outcomes were. And this is where some of the data came where babies born to mothers with CF were more likely to be born preterm, meaning less than 37 weeks, potentially have congenital anomalies, but that has not been reproduced in later literature. And that there is definitely, I think, a signal of mothers having more preterm labor and gestational diabetes. So that is one of probably the biggest risk factors to counsel women with CF on, is there is definitely an increased risk for gestational diabetes. That's something to partner and talk to your OB-GYN colleagues about making sure that they're screening well. And that's okay. That is something that can be dealt with. It just needs to be that they ensure the screening happens to be aware of that. So just a quick summary, because that's a lot of information on what we know about mom's health when it comes to being pregnant, is that there's no survival disadvantage to being pregnant, which is wonderful. The impact on lung function and exacerbations are less clear, but at least the signals are telling us that in the modulator era, that's looking good. There is still an increased risk of gestational diabetes. And the other thing I didn't touch on as much is there's still an increased rate of C-sections that are used for delivery. There's still a lot to understand about that, because that may also be practice-based, that OB-GYNs felt that may be what is necessary. I'm not blaming them in any way. I think that is historical on what they knew, and there's not enough literature yet to guide them. So it's not clear that those C-sections were in any way urgent or emergent or necessary, but that's the data we know. When you look at infants born to mothers with CF, and I caveat this with every single one of these studies is before the CFTR era or CFTR modulator era, that babies were more likely to be born preterm, low birth weight, and then again, very debatable about congenital anomalies. But I just wanted to summarize that so you kind of have your take-home points. So with that, I also want to just highlight, I know that this was brought up a second ago, that there is an ongoing study right now called the Mayflower Study, which stands for Maternal and Fetal Outcomes in the Era of Modulators, that's being sponsored by the CF Foundation and TDN, and myself, and I think probably many of you know Dr. Jennifer Taylor-Kauser at National Jewish. We are co-leading this study, but we're really excited because the whole point of this study is actually to collect very granular information on females with CF who experience a pregnancy in the modulator era. They did not have to take modulators, but as you probably could guess, we're finding that over 95% of the people who've enrolled in this study are on modulators. And we're also collecting very granular data about the births and even following the babies born to these moms for 2 years post their delivery to understand all the impacts of being born with a mother with CF, whether that mother with CF stayed on modulators, et cetera. I'll just tell you a little bit about it so you can know what's to come. But over 40 sites in the United States participated in this. We actually had it's fully enrolled now. Now we're following data after these moms have either delivered or following their babies. But we have over 300 females that have enrolled. We're getting data prepartum, meaning in their first, second, and third trimesters of pregnancy. We're getting data at delivery about all sorts of details on how they were delivered, what happened. And then we're getting postpartum data on the mom and baby for almost every 3 months for 2 years after their delivery. And just to show you a few of the questions we're looking at, the primary one is really to focus on the mom's health and lung function, but there are a huge number of secondary things that we're looking at, including obstetrical complication, pregnancy-related complications. We're getting mental health screens on the moms throughout this to understand the impact that pregnancy may have that may be unique for a mother with CF versus the general population. We're also doing some really important sub-studies, including looking at pharmacokinetics, or really the metabolism of CFTR modulators, not only in a female with CF while they're pregnant, but in the babies when they're born and afterwards, and those being breastfed, to understand how much modulator are they receiving, are we finding any complications from that, et cetera. And there's also a sub-study of continuous glucose monitoring in the mothers to understand this issue of gestational diabetes and what might we need to do differently to better control that, catch that, et cetera. So as I mentioned, we have over 300 enrolled already. As of March, we had 270 mothers with live births. That was just the number that had delivered at that point, and 200 babies that had been born, because there are fortunately some twins, which is really exciting too. So I'm not going to go into the details other than to say we're getting a large spectrum of people we're excited about. And I think we're very excited about some of this data that's going to be collected that you really can't collect in a retrospective study. So you can't get mental health screens retrospectively. You can't get respiratory symptoms, and you can't collect all this data on the babies. And the pediatricians are really helping too, because they're providing a lot of the baby milestones, et cetera, to learn about this. And I'll just briefly mention, there is a United Kingdom study that is launching currently called the Matriarch study by Dr. Imogen Felton and Jane Davies, where they're similarly going to do a very detailed look at pregnancy. And the nice thing now is in the era they're doing it, they're also going to catch some of the vanzacaftor data that's not going to be in the Mayflower study. So lots of excitement there. And I just want to, and for time's sake, I'm just going to mention a few things briefly, and I don't want to forget the males. But this is just to say that modulators are definitely seen by those infants when moms are taking modulators. We know this from a lot of studies. People tend to ask things about what's the impact. And again, we don't know. Sorry that this isn't a build. I'm just going to tell you briefly a couple of guidance pieces out there already are that people should think about if a baby is exposed to modulators in utero or while breastfeeding, that you should think about monitoring those babies' liver functions, just like we do in people with CF on modulators. Another thing that has come up is thinking about monitoring their eyes for cataracts, again, just like we do particularly in young people with CF who are exposed to modulators. These are not things we know about, but case reports have shown that there are some elevations in LFTs or eye findings in some of these babies. So we don't want to think that it's just a given that there's no problems. I think with every medicine, there's some benefits and there's some risks. And these are important discussions to have as people think about and ask, are there any consequences to being on a modulator while I'm pregnant, et cetera? Because there might be, and we don't know. And we want to make them aware of what they can do to make sure that they catch any of these that might be out there. So I just want to also point out another really critical thing to understand is that babies exposed to modulators in utero may have a completely different trajectory than babies who are not exposed to those. And this was a baby actually born to a mother with CF who actually had a father that was a carrier of CFTR. So it turned out that baby was actually homozygous for the delta F508 mutation, meaning that baby had CF. The mother, just by timing, was going to be starting on Trikafta 6 weeks into her pregnancy. It was relatively new, but she went ahead and decided to stay on that Trikafta during her pregnancy. However, about 20 weeks into that pregnancy, the baby was found to have echogenic bowel. For those who may not know, that can potentially be an indicator of meconium ileus in utero. Interestingly, as that baby was monitored at about 32 weeks, that meconium ileus resolved. And when that baby was born, that was a baby girl born full term at 39 weeks. She was born with normal weight, no meconium ileus. And when you look at some of her findings at birth, her IRT, I know that Amit mentioned that earlier, it's immunoreactive trypsinogen. It's one of the markers for pancreatic insufficiency, that it turned out to be in normal range. Her fecal elastase turned out to be in normal range. Her sweat test, close to normal range essentially. But what this means in a great way is some of the typical things that a baby with CF was born with. By being exposed to a modulator in utero, this baby didn't have. Amazing to think that a baby can be born without pancreatic insufficiency, without these things, but so much for us to think about in making sure, one, we don't miss these babies at newborn screening for our traditional way that we used to screen, and really encouraging people who are thinking about having babies of getting partners tested, et cetera, to ensure that's not missed. And then the other thing to remember is they don't necessarily have access to modulators when they're born either. And so though they may have had exposure, if there's mothers not breastfeeding or the amount coming through breast milk isn't the same as what they were seeing in utero, you may see a lot of complications or consequences hit in those first 2 years of life. But many of these can be managed or dealt with if we identify these babies. And so it's a whole new world of how we used to think about newborn screening. So just, being mindful in getting the right information and talking to people who may not all be aware of this, as it's a relatively new field. I'm going to skip through some of this because I don't want to forget about the males. And I will tell you, you may not want to sit in a middle seat of the airplane when you're doing your slides, because I got lots of looks when doing this. But it turned out fine. They were very understanding. Just, I think we don't talk about male fertility nearly as much, and I feel bad that I'm not spending as much time on it, but a lot of it is because we don't know as much. What I do want to just make sure the take-home points are about this is the majority of, unlike females, the majority of males with CF are infertile. And that is because during development, they don't develop the vas deferens. This is this absent tube. So you can see this is the typical anatomy where you would see sperm be made in the testicles, go through the epididymis, through this vas deferens and out the penile shaft. Whereas in CF, this sperm is made, but it doesn't have that path to get out. So what that means is males are infertile, but they don't have sterility, meaning they can still have babies that are biologically theirs, that are healthy, et cetera. It may just take reproductive technology. And importantly, this again, I'm not going to spend a lot of time on it, but it comes down to the fact that there is huge amounts of CFTR present in that vas deferens. The other thing is this is occurring in utero. So most males born are not going to have that vas deferens at birth. So I know many of my patients now are asking, now that I'm on a modulator, could I be fertile? It doesn't work that way, the way it's working in females, because this tract did not develop up front. Now, in those babies I just described who are getting exposed to modulators in utero, I will say the first case report was actually published recently with a baby exposed to modulators in utero who had a vas deferens. So again, the whole thing is the field is changing, but it's really important to tell your already born males it's not likely. They should still get tested and have the evaluation, but I think there's some misconceptions on that aspect, and to just make sure you're clear on that. Diagnosis-wise, it's physical exam, a semen analysis, and an ultrasound or MRI of the scrotum that can be done. And just don't forget, it's important in males to check testosterone levels as well. This is another area where a lot of research is ongoing, because we used to think testosterone levels were low in most males with CF. We're not sure that is necessarily the case anymore, and there's a lot of work going on there, but you want to make sure those levels are in a good place before they're thinking about going through reproductive technology, et cetera. And I just want to briefly show you some of those so you can understand that as you're thinking about it for your families or counseling people. And I'm sorry to have needles pointing at testicles. I'm sure that's making some people cringe. Not my intention, but so basically what has to happen is they have to go through a procedure. There's a few different options of essentially either a needle or a scalpel, taking a very tiny piece of testicle that has viable sperm, capturing that sperm, and outside the body harvesting eggs for their partner, putting those together to create an embryo, and then going through procedures, which can be in a couple different forms. One is called an intrauterine insemination, where you implant that past the cervix into the uterus of their partner to have a baby that way, or true in vitro fertilization, where you implant the actual embryo into the uterus of their partner. And many, many people have had successful babies this way. It's wonderful. In my mind, I think the only negative, unfortunately, at least about this country, is that this is not classically covered by insurance. And that tends to be a barrier, that I'm very sad about for our males. But there are some organizations that are helping support that, including, I know the Boomer Esiason Foundation has a program to support some of the costs. So, reach out and ask, because we're hoping to help support more males that are interested in building their families. And just in the last minute, this was just about, the fact that the vas deferens can develop with modulator exposure. But I want to highlight one other study that Tracy Kazmersky and colleagues are doing, because not only is the part of reproductive health important, but being a parent is important. Because you think, yes, you may get through the pregnancy, you may get through the reproductive technology, but then what does parenting look like? We know very little about that. And I'm sure, as many of you know, it's not easy for sure. And your kids are going to bring home illnesses. You're going to get less sleep. I think the stress of inflammation is going to come about, et cetera. And so we're slowly learning about that. And there's an ongoing co-funded NIH and CF Foundation study being led called the HOPE study to look at outcomes, health outcomes in parents with CF. So we're excited to hear more about that. And then finally, I always feel bad framing a discussion that's about males and females, because I understand, recognize, acknowledge, and support the fact that gender is a spectrum. And I also want you to realize there are studies ongoing out there to support understanding being part of the LGBTQIA community and having CF, which has its own many unique challenges. And many of us are coming together to partner in studying this, again, by support from grants from the CF Foundation that have continued, regardless of our political environment, to understand these questions. So I just wanted to put that out there. And with that, I just want to conclude by saying that I really think sexual and reproductive health is increasingly important. We're seeing more pregnancies, but, at least rest assured, well, the answers yet, there's a lot of studies ongoing and people who care about this topic. And, big thanks to the people I take care of in clinic who ask me questions and inspire me, I think, to want to know more. And a huge thanks to the community of people with CF. All of this, the sharing working group I talked about, which since starting to work with these people, we've done so much more in terms of trying to answer these questions. The Mayflowers team running these studies, and, my patients and my team, who I think have really inspired me as well to want to do some of this. So thank you for your time. And I'm sorry if I went over. I tried to stay on time.